Order. I call this meeting of the Standing Committee on Health to order. My name is Suzanne Lonis-Croft. I am the chair of this meeting, and today we will hear from the 811 program regarding 811 Nova Scotia. I remind members to put their phones on vibrate or turn off. In case of emergency, there are rules that we did not acknowledged before because we are in the chamber. If there is an emergency, we exit Granville Street, go down to Hollis Street to the courtyard outside the art gallery, and that's where we gather. So we were advising people to go to the Grand Parade. That's when you're in the committee room at 1Gov. So please remember that when you're in here, you exit and go to the art gallery. I will like to note that there are members absent only because they're stuck in traffic. There's been an accident on the Bedford Highway, so they are delayed. They will be coming. We will start introductions, starting with Ms. DiCostanzo.
Good morning and welcome everyone. I'm Rafa DiCostanzo, MLA for Clayton Park West.
Good morning, Keith Irving, King South.
Good morning and thank you for being here. I'm Margaret Miller, the MLA for Hants East.
Good morning. Thank you again for coming. My name is Colton LeBlanc, the MLA for Argyle-Barrington.
Good morning. I'm Barbara Adams, the MLA for Cole Harbour Eastern Passage.
Good morning. I'm Susan LeBlanc, MLA for Dartmouth North.
Good morning. Tammy Martin, MLA, Cape Breton Centre.
Our clerk is Judy Kavanaugh, and our ledge counsel is Mr. Gordon Hebb. I'd like to have our guests introduce themselves and do opening remarks.
Thank you. My name is Dr. Todd Howlett.
Good morning. My name is Natalia Gallant, and I'm the Manager of Quality and Privacy within the Telecare program.
Good morning. My name is Wendy Bootlayer. I'm the Manager of Operations and Clinical Services with 811 Telcare.
Excuse me, Dr. Howlett. The mic will turn on when I say your name.
I'll figure it out eventually. Thank you. My position with the program is I'm the Medical Director for Teletriage 811. So I'll begin, and thank you for the opportunity to come before you and talk about Nova Scotia's 811 program. We look forward today to having a conversation with you, and we hope to share with you what 811 does, clear out what it does not do, and share some of the opportunities that lie ahead. As you may know, this year marks the 10th anniversary of the 811 program, ergo it began in 2009. The 811 service has a number of facets that I would like to take a moment to outline briefly. First, and probably best known, is symptom teletriage. For many of you who may have used the program, this is the part of the program whereby you call the program, you speak to a registered nurse, and you describe your symptom, and through a series of evidence-based guidelines and an experienced nurse, a plan is sorted out as to where you should best go to receive care, up to including, in many cases, that you don't need to go anywhere and that you can be managed through self-care at home. We share a lot of health information in addition to this service, and we have a large number of what we call HITs, or health information topics. Those can be found both by reaching us and online. We do a lot of what we call provider referral. We have a large community database, and we serve as a database for the province, and during these times we refer patients to mental health lines, to food banks, pharmacies. We identify walk-in clinics, and we have some services available also for our First Nations. There are two other important programs that some people don't know are associated with teletriage. Those include Tobacco Free Nova Scotia, and Tobacco Free Nova Scotia is an online and telephone consultation for people attempting to quit cigarettes and smoking. In addition to that, we have gambling support network, again, an online and telephone consultation service where we counsel problem gamblers. In addition to all this, 811 serves as the repository for the Need a Family Practice list. It is important, however, to note that the content of this list is not ours, but is managed by the Nova Scotia Health Authority. And a couple of other important items that I wish to share before we start. One, and perhaps a fun fact, it's nothing to worry about.
No.
All right. It's like maybe I'm done, you know? Is our nurses work from home. And we can talk about that more later. And through our tripartite agreement, we also provide services to one of our sister provinces in PEI. And the last fact I'll leave with you before perhaps we can start is that the 8-1 program is supported by 2 clinical advisory committees that are, whose membership are often local clinical experts that support both our mental health programs, Gambling Support Network and Tobacco Free Nova Scotia, as well as our teletriage program. And they provide input as related to clinical guidelines, quality metrics, and outreach. And that's all I had to say to start.
Okay. Well, thank you, Dr. Howlett. We will open up questioning, starting with the PC Caucus. Ms. Adams, for 20 minutes.
Thank you, Madam Chair, and thank you, Dr. Howlett. I'm wondering if you could start off by giving us some numbers. And I'm wondering when the last time there was an 811 report that we could actually refer to and look at. So for the 10 years that the 811 system's been in place, we don't have a good understanding of the breakdown of the number of calls, how many were for mental health, how many were for whatever. So I'm just wondering if you could give us a sense of some numbers as to how the numbers break down.
Dr. Howlett?
Sure. I'm going to ask Natalie to my right to provide some of the numbers. I think she has some data that you might find helpful, and certainly you can ask more questions after that.
Ms. Gallant?
Thank you. So these statistics are from April 2018 to June of 2019. So in terms of total patients serviced for the program would be 114,000. The majority of our patients are repeat patients, so that would be a total of 80,000, which would be approximately 70%. In terms of mental health type calls to our service, it would equal to about 2% of calls.
Ms. Adams?
Thank you, that's helpful. Given that last year, the number of people who were without a family practice doctor or clinical nurse practitioner went from 45,555 to 51,802. So that's an increase of about 13% more without a family doctor, according to the Nova Scotia Health Authority stats. What percentage of people calling 811 are without a family doctor?
Who'd like to take that? Ms. Gallant?
That wouldn't be a statistic that I have here today.
That you have?
That I don't.
Okay. Ms. Adams?
Thank you. Is that a statistic you collect?
Ms. Gallant?
Part of our call process is that we do ask patients if they currently have a primary health care provider. So that is a part of the call process that we follow.
Ms. Adams?
So is it possible for you to get us that statistic?
Dr. Howlett?
Yes, absolutely. I don't see any reason why we couldn't provide that statistic. Yeah.
Ms. Adams?
Thank you. So I'm surprised that only 2% of the calls were for mental health. So I'm wondering, when those calls come in, if it's a physical ailment that's considered an emergency, you would direct them to either a walk-in clinic, family doctor, or emerge. When mental health calls come in, what's the triage instruction?
Dr. Gallant? Oh, sorry, Dr. Howlett.
No, Dr.
So thanks for the question. So we have a guidelines. It depends on what. Perhaps I can just take a moment to talk a little bit about our evidence-based guidelines, just to educate the committee a little bit, if I could. So we have some 300 adult and 300 pediatric guidelines that are based on various symptoms. They might be shortness of breath. It might be weakness. It may be and we have some mental health guidelines as well that are related to people who are distressed or presenting in it. The guidelines work in such a way that it's important to note that the system is not diagnosing or treating patients other than in what we call self-care. So people call in, and through the nurse interacting, and it's important that it's a registered experienced nurse interacting using a guideline, we come up with an output. So as you mentioned, so our outputs, broadly speaking, and I'm going to get to the mental health one, but I think it's important to situate it, if I may, would be 911. So there are some situations, if I'm calling in and they called us instead of 811 perhaps by error or mistake, or it becomes clear that we should be sending an ambulance. Go to emerge. And then we have a number of different ones: seen within 24 hours, seen within 48 hours, seen within 72 hours, seen within a week, seen within 2 weeks, and up to home care. And that's basically around the idea that we hope that you'd be able to see your family doctor within 2 weeks, and that may not be possible, as you've mentioned. For mental health, it's similarly. And one of the important outputs that we partner to is both mobile mental crisis and the mental crisis line in the rest of the province. So, and in the same way we've done this with poison control and other organizations within this province that provide great care, we're not here to take over their care, but rather to partner with them and to work. So in many cases, one of the outputs may be, we think you need to go to mobile crisis. Now, on the other extreme, if we're worried about somebody, so say you called in, and remember, this is not, I want to be clear, this is not 911, this is 811. So you're not calling, you're calling 811 because you may not know what's going on. But during that conversation, we have had scenarios where we have been significantly distressed by somebody to the point that we've actually sent a wellness visit to their house. So we've actually contacted the police and sent somebody to check on the person. So say somebody was incredibly distressed, was threatening to harm themselves, and we were worried about them, we would actually do a wellness check and actually send somebody to their house. So we do that.
Ms. Adams.
Thank you for that information. The cost estimate for one call, I've seen documented that's around $52 per call. And some have mentioned that a physician visit costs $38. So I'm just wondering if you can comment on whether those two numbers are accurate, and why you think there's a difference to that, and certainly whether that's a good value.
Dr. Howlett?
Yeah, thanks very much. And it's a great question, and I've heard that quote. In fact, one of my colleagues, I think it was Barb O'Neill, had actually put it, and I know Barb, she's an excellent physician. I think, so let me say that the cost estimate per call, it's a simplistic, overly simplistic analogy. There is a lot that 811 does beyond just the calls that could not be provided by a physician as such. First of all, it's available 24/7. It is available to every person in this province, assuming you have a phone. It provides continuous service, data and information that a family doctor may not have. And in addition, one of the things we talked about, and we like to talk about it, it is a bit of a safety net for the community as well. And I'd like to highlight that shortly after we started this program, if I may, in 2009, if you guys remember the fall of 2009, we were hit by H1N1. I know. And we have some volumes here that our call volumes went up. I don't know if you can see this, but anyways, it peaked up. We went 10 times the call volumes overnight because people needed to respond and get information, and 811 was there to do it. It was extraordinarily challenging. We had to hire nurses beyond the province to actually cope with the call volume. So this is one of the services that 811 has that's not included in this $50 per call, because that's part of what we're doing. And it's almost like I use the analogy that you don't know that you need a smoke detector unless you have a smoke detector, right? And what's the cost of a smoke detector, because it has to be there. The other things that are going on, and hopefully we'll get during that some of the questions, and I'll try not just to bore you with all the things I want to say, but I do want to mention that, we even have a role in medical surveillance in the province. So yesterday, Dr. Rob Strang, our Chief Medical Officer, was visiting, and as part of that, with emerging illnesses and the like, we're looking at using the calls that we're doing at 811 as a role for the medical surveillance of public health in this province. So somewhere hidden in that soundbite of $50 versus $30 is, and I understand what's going on with the family physicians and their concern about their pay and everything else, but I think there's so much more we're getting out of that. So I'm obviously convinced that there's value to it, and I think there's some evidence that exists.
Ms. Adams.
Thank you very much, and certainly everybody that I've talked to finds the service of tremendous value, especially at 3 in the morning with a sick child. I wonder if you could tell me how many of the calls are about children versus adults and versus seniors.
Who? Dr. Howlett?
So so I apologize for that. We brought some data about our top 10 clinical guidelines are both adult and pediatric, but we did not bring what percentage are pediatrics. But we can bring, but we can certainly make that available to you and be happy to do that. I can share with you in the last, from April of last year to June of this year, the clinical guidelines used, just to give you some interest of that, the top guidelines used, one was chest pain for adults. The next one was a medication question call around adults. People are calling medication. Many of those may, depending on whether we deal with or not, may actually go for poison control. They do some medication concerns, and we work back and forth. Pediatric cough is the third guideline, perhaps not surprisingly. And there is some seasonal variability. So in our clinical advisory committee, if you were to come and watch it, you would see we know when flu season arrives. We know when RSV season arrives, because we start to see some of these guidelines going on. And I wanted to refer earlier to my conversation about medical surveillance. We can start seeing these calls go up, and working with Rob Strang, we can help some of that. The third one is abdominal pain female, is the third one. Diarrhea, adult, vomiting, adult, colds, pediatric, vomiting without diarrhea, pediatrics, headache, adult, and back pain, adult. Those are the top 10 guidelines used that people are calling in for.
Ms. Adams.
Thank you. I'm wondering, given the fact you mentioned back pain and medications, whether there has been a consideration to having a pharmacist call a patient back, or a physiotherapist call somebody with back pain. So I'm just wondering if there's any opportunity to expand this service to other allied health professionals.
Dr. Howlett?
Thank you for the question. Interesting enough, we do have a pharmacist that actually sits on our clinical advisory committee. He's from Northern Zone, and he's fantastic, and we do a lot of work through it, and we've explored that. The challenge about 811, just like the challenge of, is we have to be a generalist, so it is very hard to, say I have a dermatologist do skin, and we're trying not to diagnose, but to have a high-level response to what we do. But having a pharmacist, for example, on our clinical advisory committee and providing input into our clinical guidelines is very helpful. And if I can, I'll just take one more moment to say, our clinical guidelines come to us from an outside author. We partner very clearly with our local health experts to ensure that what we're suggesting is compatible. So for example, breastfeeding, we have an organization. So we wouldn't provide advice that wasn't in any way discongruent with what is here. And I'll give you an example that happened yesterday. We have a new guideline coming around colonoscopy. So everybody may have had a colonoscopy or endoscopy. Nobody wants to talk about those things, but an unfortunate necessity. One of the things we were finding, which was incredible, was that often people would lose their preparation instructions. It would be the weekend. They would be calling 811, and they said, I've waited, 8 months for my appointment. I don't have the instructions. I need to get this prep right. What do you want to do? So interesting enough, we actually now have a senior director and 2 physicians that are in charge of endoscopy in the province. So I called them up and I said, so what's the plan? Oh yeah, we're working on that. I said, what do you mean you're working on that? Yeah, there's 45 different preparations that each physician has. I said, well, that's crazy. Sorry, that's the right word. That doesn't make any sense. So they've now standardized it to 2, and I'd like to think we were part of that, to challenge them to standardize it to 2 if you have renal failure, if you don't have renal failure, and that they've gotten, and that we have these guidelines that we've shared with them. They're going to provide some input. And in the future, a couple months from now, if you call in and you've forgotten your preparation, we've spurned the province to say, let's standardize it. There's not enough evidence to have that many, 42. We can have 2 standard ones, and we'll be able to provide that to you. You can go to the pharmacy and get your preparation and hopefully not miss your colonoscopy. You might want to miss your colonoscopy, but you shouldn't, yeah.
Ms. Adams. Oh, sorry, Dr. Howlett.
Sorry, I can talk forever. In answer to your question, we are very important, and Natalia and Wendy reach out regularly to experts in the field to inform our guidelines. Yeah.
Ms. Adams.
Thank you. I'm wondering if I call 811 and I get instructions to do one of several things, I'm wondering 2 things. One is, do you track whether I actually follow up on those? So could we say, 40% are all sent to Emerge, and we know that 22% follow up on that? And the other thing is, does a physician get notified that I've called 811?
Dr. Howlett?
Yeah, both great questions. So on the first question, we would love to do some outcome research on what we're doing. Unfortunately, this is the privacy officer next to me. There are some privacy issues for us to actually go and find out if you attended at a facility. And it is not simple for us to, you would think that we could just go and say, did you show up in Emerge? But we can't do that without your permission. There was some recent external review that looked at it, and it talked in generally about whether people follow the advice or not, and generally they do. We also try to, at the end of a call, and it's fraught with some problems, to say, this is our advice, can we ask you what would you have done had you not called 811? And we have some of that data, and if you'd like to see that, we'd love to share it with you. But be aware there's a bias there, right? Because we've asked you at the end of the interaction, we've given you advice, and then we said, what would you have done beforehand? It is very difficult to say, hey, before we tell me about your chest pain, tell me what you were thinking of doing. So it's hard to do it at the beginning of the call. We want to get to the chest pain. We don't want to ask you too many questions about what you were doing, and you're going to think it's a little crazy if you're like, what I want to do is call you, so I did that. So yeah.
Pardon? For a bit over 4 minutes. Ms. Adams.
Thank you for that. Apparently, there was an independent consultant retained by the department to review the 811 system in 2018. And I'm wondering if you have that report with you, and if so, what were the major conclusions? Dr.
Howlett?
Thank you. We do not have that report with us. There was a number of very positive things that came from that, and I can speak to a couple of them if you like. One of the critiques, and I'm if you know me, I like to talk about the elephant in the room. One of the critiques about 811, and I'm an emergency doctor, so 1-800 go to emergency department. I can tell you our breakdown from our dispositions of what's happened. So a lot of healthcare providers who are in busy emergency departments, including myself and my colleagues, see the denominator and not the numerator, and not denominator. We know the people that were sent in, and we remember them, but we don't know the people that weren't sent in. So by our very nature, we have a bias. But in the last year, all the people that called in, approximately 4% of people were sent to 911 of all the calls. 1.9% went to poison control. 0.3% of people were forwarded to the mental health crisis line. I know I've heard a number of members, mental health is, and in particular parts of this province, is a significant concern. 18.7% were directed to the emergency department, not everybody. And then those other dispositions, primary healthcare provider and the like, works out to be about 42%. Self and home care worked out to be 30% overall. So I'm not an expert in queuing theory, but let me explain. Ideally, if everybody calls to us and we can arrange that you could be seen tomorrow or the next day, then it would help the system in some ways to determine. Now the challenge is you have to have an appointment tomorrow or the next day, and that's where the walk-in clinics sometimes come in and other things. Those recommendations we actually talk about primary healthcare provider, and but the nurses spend a lot of time in every area. So if they're up in Cape Breton or if they're on the South Shore and the disposition is the next day, how that may look may be very different. If you're lucky enough to have a family doctor who has a same-day appointment tomorrow, great. If you're not lucky enough to have that, you may need to go to a walk-in clinic. If you're not lucky enough to do that, you may need to go to your local CEC. So just though we say primary healthcare provider, there is a lot of problem solving done by the nurses in each area to figure out where the person needs to address care and get their care.
Ms. Adams.
I think I have time for one more question, and it's a bit off topic, but according to the Nova Scotia health authorities, by the number of beds in 2017-18 report was 3,554, and the number of beds in 2018-19 was 3,150, so it's a loss of 404 beds. And I'm just wondering, where did those beds go, and where were they lost?
Dr. Howlett?
What kind of beds are we talking about?
I don't know. It's according to the Nova Scotia Health Authority beds. It just gives a list of the number of beds in the hospitals and says those
time has expired for the PC caucus. We'll turn it over to Ms. Martin for the NDP.
Thank you. Saved by the bell. Thank you very much. So I'd like to talk about the need for family practice and who actually is finding a doctor as opposed to just coming off of the list. And are you tracking the demographics of those people who are finding doctors? Dr. Howlett.
Yeah, thank you for the question. As I mentioned in my opening remarks, the connection to 811 and need of family practice is purely that as to collect the numbers and pass those on to the Nova Scotia Health Authority. So as such, we do not actively manage that list. And I actually don't have the numbers for the list because the role of 811 was we have a number, people can call there, and all that data is then passed to the Nova Scotia Health Authority.
Ms. Martin.
Thank you. Do any doctors actually have to take patients off the list, or is it fully optional for them? And I understand that there was an incentive program in place that offered doctors additional compensation for every patient that they were able to add to their roster who was on the 811 list. But I think many people aren't clear as to whether calling and registering themselves as someone in search of a family doctor will give them priority over searching on their own. So is that a priority list, being on the 811?
Dr. Howlett.
Thank you for the question. I'll refer to my further previous answer. We don't manage the list, and the way that people are taken on the list is managed by the Nova Scotia Health Authority.
Ms. Martin.
Okay. It strikes me that the service produces a ton of useful data, both about the service itself and about the health issues people are facing in Nova Scotia. What are we learning from the 811 data about health issues in Nova Scotia? And is anyone looking at the data in a systematic way? And is that data available to health policy researchers?
Dr. Howlett.
I really appreciate that question. It's a great question, and I think we're challenging ourselves to do just that in two ways, if I may. One is by through working closely with the Nova Scotia Health Authority, specifically around the new programs of care. So we're systematically meeting with each of those. So as you may know, that Nova Scotia Health Authority now has programs of care on cancer care, on mental health and addictions, on emergency care, on critical care, and as such, they have a senior director and a senior medical physician. So we were making a point of reaching out to them. Last year, we sat down with Drew Bethune, who many of you may know, and his director, who's for cancer, and talked about what their challenges are and what we might help them with. So this isn't specifically about data, but a shared opportunity. So, and one of the things that came from that, it may or may not work out, but that a lot of people who were getting IV chemotherapy are now on oral chemotherapy agents, which are still quite expensive, still quite effective, and now the issues become compliance with taking the oral medications. So they were exploring whether they should have a nurse calling out to ensure that somebody who now lives on the South Shore or somewhere else that doesn't come in for IV chemo is actually getting their chemotherapy agents. And I said to Drew, well, or Dr. Thune, perhaps maybe we could partner together if we already have nurses and we could provide that service, and it might be cheaper for the system than building another system on top of what we had. So that was, and then we're trying to do that each step. One of the people I hope to meet is the new vice president for research that the Nova Scotia Health Authority has. I'm quite passionate about doing some evidence-based and outcome research, and I think the program is well placed for that, to meet with her and find out what data we can glean from this. Primary healthcare is another example. We have a meeting coming up with Dr. Rick Gibson, Dr. Lynn Edwards, to look at what we might learn from 811 when it comes to primary healthcare. So it's a great question. It's certainly a focus, and it's certainly something we want to do, is to share and the province deserves us to do this. We need to get this right, and we need to figure out what can we get from this system to show the Nova Scotia Health Authority what might be needed. Yeah, absolutely.
Ms. Martin.
So just to follow up on that then, is the data that's being collected being studied and evaluated to provide suggestions and or comments to the NSHA?
Dr. Howlett.
Thank you. Thank you. Yes, we are doing some of that through our clinical advisory committee. One of the people that joined us recently is a researcher and has an interest in this from the IWK. A large number of our calls are from the IWK, and we're exploring how we might do this. We talked about some outcome research, trying to figure out, what's actually happening to people. Do we have that right yet? No, I don't think we do. But I think we will do that. One of the neat partnerships that's changed recently is our program was taken over from EMCI from McKesson, so we're a third party. EMCI does do a lot of research, and we're having some meetings, and we're collaborating both on continuous quality improvement projects, and we're hoping to with research as well. Because they have more resources around resources than we have. So yes, I mean, we're in the infancy of that, but that is exactly what we intend to do.
Ms. Martin.
So to clarify then, has the data not been used for the last 10 years? And is this a new approach?
Dr. Howlett.
No, I don't think that's a fair characterization of what I said. I think that we have always shared the data. We have always passed the data on to our partners. Formal research has not been done on this. I think that's fair. But we did a micro research project with a former dean. There's different levels of research. There's publishable research and there's CQI type research. We have continuously fed that data back to various stakeholders within the organization when we found something that seemed to miss. So there has been a lot of interaction with stakeholders that within the province. I think what we're suggesting now is we might be able to take it to another level and leverage some of the resources that exist within EMCI. I mean, I think you guys know we have one of the premier pre-hospital systems in the province, our EHS system, and they're doing a lot of research, and we're hoping to partner to do even more with what we have now. But it would be wrong to say we haven't done this. We have. It just, I think we can do more.
Ms. Martin.
Thank you for the clarification. So aside from H1N1, what has the trend been in the usage of, you spoke about H1N1 showing us a significant increase, but has it been an upward or downward trend?
Dr. Howlett?
So, I think the last conversation we had is overall the numbers have been slightly less, and one of the external reviews question as to why. The premise had been that the program we should see an uptake and increase through that. One of the challenges that we have at 811 is that we are not responsible for our own advertisement. It's all done through the Department of Health, so we're encouraging them to maybe make more fridge magnets or, to advertise it. I think that's getting better. During some of the conversations we had, the hypothesis the hypothesis that 811 numbers should always increase is something that particularly I'm not sure about. I'd like to think that a large part of what 811 does is education. So if you're a young mother and you have 3 children and you have a fever and you don't know how to treat it and you've called 811 and we've given you advice and we've educated you, then perhaps you don't need to call us the second time because we've done that. I do think, and a lot of what I do, we always say more is better, and I think we could do a better job advertising the program. There's no question, but I'm not sure that the slightly decreased numbers necessarily is a bad thing. It may mean that we're actually educating people. But we can provide those numbers again, and I apologize if we don't have all these numbers in front of us, but we could certainly tell you what the numbers were and the calls for the 10 years of the program. I'd be happy to provide that for you if you like.
Ms. Martin.
Thank you. And earlier you spoke about in 2010, there was a reports on HealthLink 811 that would include analysis and trends. So what is success for 811 at the end of the day? What are the outcomes that 811 needs to meet at the end of the day or at the end of the year? And how do we know that 811 is actually is successful?
Dr. Howlett?
Thank you. I'm not sure it was 2010 was the year. I think the report was from 2018. Maybe it was in the last year. So, it's a great question. So, and the external report broadly looked at whether we had value and whether it was value for Nova Scotians, whether we were, whether people that called us who went to the emergency department in a match control might be sicker, I'll use it in simple terms, than people that went on their own. There was some data, they got some permission to follow people through using some MSI billing number. They showed during that time that for matched patients, and I may not have it exactly right, but for matched patients, the people being referred by 811 were at higher acuity levels. So for those who and I imagine many of you are aware that in the emergency department, and I'm an emergency physician, we use this CTAS level, Canadian Triage and Acuity Score level of 1 to 5, with 1 being the sickest patient and 5 being the least sick patient. And it's sort of a proxy for sickness. The idea being, if we're doing CPR and you're a 1, and if you've come in because you've run out of your antacids, you're a 5, and you're going to Boston this weekend, you really want to make sure that you don't have heartburn for that would be a 5, and there's all kinds of stuff in between. Now there's some 5s that are not quite that frivolous, but so it looked like the data suggested that the people referred by 811 were higher acuity and different than those people. success is an interesting thing, because I guess success is in the eye of the beholder. We have a performance contract with the Department of Health, and there's deliverables in that contract that we have to deliver certain calls. We were one of the last provinces to adopt an 811 system, for whatever that's worth. The overwhelming responses from the people that use 811 are overwhelmingly positive. We will always hear the negative of 811. We are constantly struggling and it's a struggle in our CAC to find the balance between making sure we do not miss anything serious, but and creating a program that's sensitive enough not to miss a serious case, at the same time not being having sufficient specificity, so we're not sending everybody into the, those are the two risks of the program, I'll be honest with you. One is it seemed to be, we're too sensitive and everybody's sent in to be seen by somebody, and the other thing is we miss something, right? So I think it was wrong to have characterized the program early on that this would be a way to divert patients from the emergency department. I don't think there's any evidence, there's never any evidence that's the case. We just change the people that go. There may be people that, that went to the emergency department or that should go to the emergency department that didn't. As an emergency physician, we sometimes hear about the person that stayed home, they had heartburn and they had a heart attack 3 days ago and their heart's in trouble now, all right? And those people we're sending in, and other people we may be not sending in, so yes.
Ms. Martin.
Thank you. So in 2010, there was an accountability report done, and in 2018, there was an external review. Typically, these are made public and published on the Department of Health and Wellness website. Can you confirm that these are public documents, and if so, that we could actually have copies of them? I believe we received the 2010 one, but nothing further.
Dr. Howlett.
Thank you for that. There was thanks for clarifying that. Yeah, the recent review that was done by the Department of Health and Wellness. As such, it doesn't belong to us. It was an external review, and I'll have to defer to them as to how they make it public, because it's not within our purview to actually make that public.
Ms. Martin.
Excuse me, thank you. So is there an accountability report published every year? And if not, why isn't there?
Dr. Howlett.
So I'm unaware of accountability. We have, just like our EHS system does, we have a performance guideline, performance requirements that are done, and accountability as such. So we have regular meetings with the Department of Health and Wellness of what our performance contract obligations are. But I'm unaware of and it may just be I need to get some more information about whether this actually is called an accountability report. We have a compliance review. Is that, you want to talk about that?
Ms. Gallant.
Thank you. So as Dr. Hallett stated, it is a performance-based contract, so there is a yearly compliance review that is completed, ensuring that certain metrics are followed within the contract. So that's completed on a yearly basis.
Ms. Martin.
Thank you. And are these public documents?
Ms. Gallant.
That would be something for Department of Health and Wellness to speak about.
Ms. Martin.
Thank you for that. When we talk about data, of course, we need to talk about privacy. So I'm wondering with 811, how do we ensure that the personal information of people contacting 811 is not at risk or distributed to those who shouldn't have that information?
Ms. Gallant.
Just to clarify, are you speaking internally or externally in terms of access of information?
Ms. Martin.
Well, I'd like to know the procedure if I was to call 811. What is your privacy policy around my personal information and where that could end up?
Right.
Ms. Gallant.
Thank you for the question. So when anybody phones into 811, there's a confidential chart that is started with their information so that we're able to document the reason for their call. Anyone having access to that chart is delivering care or service to that patient. So it is role-based access, and any access to any charts is monitored on a regular basis.
Ms. Martin.
And just as a follow-up to that, is that connected in any way through or with the NSHA patient information?
Ms. Gallant.
Thank you. So it is separate altogether. It rests within EMCI, the information. So we are an agent for the Department of Health and Wellness, who is the custodian of the information.
Ms. Martin.
Thank you. But it's not connected to my chart? So I guess to be clear, if I had a heart attack, would there be record of that in my, in my family docs chart, or if I was sent to emerge?
Ms. Gallant.
So for continuity of care purposes, if someone does phone into our service, and we do recommend that they go to the emergency department, we do ask that if we can send a referral of the 811 chart to the emergency, and if they give their consent, then we send that over immediately.
Ms. Martin.
Thank you very much. So I'm wondering too, with people calling in and their personal information being held by a third party, is that on site, on data? How is that physically held?
Ms. Gallant.
It is on site, and there was an in-depth privacy impact assessment completed at the start of the program and with each contract, ensuring that privacy standards are met.
Ms. Martin, less than a minute.
Sorry?
Less than a minute.
Okay, thank you. So is that something that's reviewed annually, privacy policies and concerns? But by the look on the doc's face, I'm guessing that's a yes. But because, I mean, we've heard recently of breaches, and sadly accidents happen, but is this something that's scrutinized frequently?
Ms. Gallant.
Thank you for the question. So privacy is of the utmost importance in ensuring the safety of patient records and patient information.
Order. Time has expired for the NDP. We'll move it on to the Liberal Caucus for 20 minutes. Ms. D. Costanzo.
Thank you, Madam Chair. And I'm delighted actually to see you guys here. I remember receiving a call 10 years ago, and I think it was 6 months before 811 was to be opened to the public, and I thought, wow, what an amazing service that we're going to have. It was something for the future that we can call 24 hours. But the call that I received was from the organization is how to provide interpreting services, as I was the president of that organization. So I'm wondering, in 10 years, I know at the time privacy was the biggest thing for me, to provide interpreters 24 hours and to make sure that they had a room where they can answer with total privacy and other things. So first, my question is, how are you providing services to newcomers in different languages? And how many calls do you receive that are from the non-English speaking clients?
Who would like to take that? Ms. Gallant.
Thank you. So we do partner with Language Line Solutions, which is an interpretive language company. They provide a language within 240 languages. It's typically, if a person does phone into our service and requiring an interpreter within a 1-minute time frame or less, we do have that interpreter on the phone. And it is part of our contract with Language Line Solutions that it is an interpreter with medical terminology, because that would be really important in providing our services. And then we also do have some bilingual staff as well, as part of the 811 service, to provide French services as well. And if there are no bilingual staff on, then we can escalate those calls to Language Line Solutions as well.
Ms. D. Costanzo.
Thank you. And do you see what were the numbers? Are the newcomers using your service? I just want to know how, how is it promoted? How is it reaching the newcomers? Because it's a wonderful service, especially if they're new to the country. What are you doing to make sure that they know about you?
Ms. Gallant? Oh, sorry, Ms. Boutlier.
Thank you. We work diligently to work with newcomers. We do outreach at the immigrant, pardon me? I work with ISANS as well, but we also go to the, I'm losing the word, we do the outreach with newcomers, is what I'm trying to say. So yes, and we work closely with ISANS, and we're building a partnership so we can learn what we can do to help them and what their needs are and what they're looking for from us, so how we can better serve them. So yeah, we're working closely with them, with ISANS.
Okay, sorry. Ms. DiCostanzo.
So I didn't hear what is the percentage of the calls that require interpreting or are from the patients who are not, or I don't want to call them patients or clients. Am I allowed to call them patients? Who are calling that have issues, medical issues.
Ms. Boutlier?
Thank you. I will refer that to Natalia, who keeps track of those statistics.
And Ms. Gallant?
Thank you. So we do keep track on a monthly basis in terms of language in terms of usage with Language Line and what specific languages were used. I don't have those specific stats, though, here today.
Ms. DiCostanzo.
Thank you. The other question I had for you is, for the future, where do you see 811? What are your hopes? What else can you do to improve, or what is happening in other jurisdictions or across the world? Is having like a Skype method, where to me is looking at it, if somebody has a rash and it's so hard for somebody to describe the rash compared to a different rash, is there a way for the future that we can have video teleconferencing?
Dr. Howlett.
Yeah, that's really exciting, and we've had some of those discussions at our clinical advisory committee. One of the challenges we presently have in this province is to ensure that we provide a universal service to all people in Nova Scotia, and because I know we're looking to have internet, high-speed internet in all areas, but it's not available at this point. So, but I definitely think, and not everybody has access to it. So I think we have to be careful just to make sure we have a universal service. But I think the future of doing that, and we've even, I've even sat down with somebody from Bell and said, perhaps there could be a biometric device on your cable box that was built in, and you would go over and put your finger on it. We know what your O2 saturation was. I mean, if we're really going to think outside the box, we need to start thinking towards something like that, and that, and then we could inform a guideline by knowing what person's saturation level was. So the actual, the future might be visual or some sort of even biometric device. I mean, we have so many of these people have this crazy thing now. And I have one of these crazy things here, and you can now get a EKG, and so to think ahead, to wonder whether this is something we could do is there. It's the art of the possible. I don't know what it is yet, but yeah, clearly it will change. There's no question.
Ms. DiCostanzo.
So what do we know about what is happening in other jurisdictions in the world that is more advanced than what we have here in Nova Scotia that we're aspiring to have? Anything like that?
It's interesting.
Oh.
Suzanne?
Oh, Dr. Howlett, sorry.
I'm gonna figure this out eventually. It is interesting. One of the things I think we need to be a bit proud about in Canada, and I'm going to speak up, is that our socialized medical system is very different than places like the States. So we often think the States are very advanced, but they're not advanced systematic in a system sort of way. So, for example, and I'm going to lead back to this question, but I want to explain this to you. So I was dealing with one of the guideline authors, and we were talking about the work we were doing between 811 and 911, which is, really important to say, what if we get something that goes to 811 to 911, or more importantly, 911 to 811? So we've explored, what if you call 911 and they're like, we don't really think you need to send an ambulance to this person. We've heard about some of the problems they have with ambulances. But maybe we can run it through 811 and come up with a different disposition with the understanding they could bounce back to 911 if we could come up with something. So just imagine that for a moment. And he was like, I would love to have a system like that, but they don't run their health system in the same way we do at a provincial level. They don't run their ambulance service at a state level. So it's very cut up. So we're leading in this sort of coordination. Having said that, yes, some other areas are using their system, and if they're in a well-to-do area, I imagine somebody's now using their Apple Watch to do all that. And I want to continue to explore those, but I'm just saying in Canada, it's a little bit different because we don't have everybody necessarily with an Apple Watch on that. So now across Canada, I think we're similar to what's going on. We are interested in, we're big fans of benchmarking. So we're trying to, and Wendy sits on a committee, but we're trying to, and it would be even helpful, if I may say, that if somehow it could be legislated that all 811 programs had to be part of a national working group. Because one of the downsides of having a third party is sometimes it's proprietary. But those of us that work at it would love to actually say there has to be a national working group and that every province's group has to be part of it, and that would help us with the benchmarking. So we've created some internal benchmarking. We've created some standards around our callback times. We monitor a great level of the stuff, and we haven't got to the quality metrics that we use, but it would be fantastic to be part of a benchmarking group. But the very nature that 811, rightly so, is provided by a third party in many provinces means that it's not quite the same. So it would be great if somehow, there could be some support to suggest at some sort of national working group that every 811 program, medical director, would have to be part of a benchmarking group nationally. I think that would be a really important thing for us to do. And would hold us accountable and yeah, so. Does that make sense what I said the last part? Yeah.
Ms. DiCostanzo.
I think so. I didn't even know if the same number is across Canada. So every province has the same number, 811. Is that something that what you're referring to?
Dr. Howlett?
Thank goodness for that, yes. 811 is the standard number across Canada. And most places are run by a third-party provider, as we are here. There is one province that does it themselves, and we interact quite a bit with that province. It's in Alberta. So we are big fans of benchmarking with other provinces, recognizing, to your point, that we may not know it all, and there may be advances somewhere else that we should be adopting. Yeah.
Ms. DiCostanzo.
So you talked about benchmarking. So where are we compared to Canada and maybe Australia or England? And how do we aspire, as anybody else is doing, have gone further or have invested more finance into this service?
Dr. Howlett?
Yeah, thanks for the question. It is difficult for us to get those benchmarks because of this proprietary sense of it. The National Health Services, I haven't looked at it for a while. It might be appropriate. Australia has some fundamental differences in the way they approach some things. There are some things to learn, but it's not completely the same. Yeah, I think there needs to be more benchmarking so we can answer that question clearer for you. I'd like, I'm here to say we've got the best program, and I think we have an excellent program. Do I have benchmarking data that clearly shows that? No. Am I desperate to get that? Yes. Yeah.
Ms. DiCostanzo.
Wonderful, and I've used your service, and I was very grateful. And when the kids were small, so it's more of a comforting, knowing going to bed and knowing that you didn't have to go to emergency that night. It has worked amazing for us, and I think I'm done with my two main questions, and I pass it on to my colleague,
Ms. Miller.
Thank you again for coming in. This is such a good news story for Nova Scotia, I think, and the work that you're doing has helped so many people. I've been one of the people, too, who have called 811 in a situation where I wasn't quite sure. Do I go to the hospital? Do I not? Maybe a doctor wasn't available. I don't remember the exact circumstances, but I know that that person on the end of the line gave me the confidence that I needed to be able to make a decision of what I needed to do. And I'm not sure. Seems to me I remember them calling back to follow up, and maybe it was quite a while ago. So, and I was even more impressed that they even called back. So, anyway, yeah, thank you for that. So, I loved hearing you talk about the future, where 811 could possibly go. Do you have anything else on your wish list that what do you envision seeing happen in the future? Or do you have something on your wish list that you'd like to be able to add to the program that you think could add value?
Dr. Howlett.
Yeah, thank you for the opportunity to ask me that question. Yes, I think the best way to think about 811, the way that helps me to think about 811, is it's a platform of which we can connect and build up with others. So we are very interested in we have this platform. It exists. We have a number that everybody knows. And we can build services around that. So in an effort, as the Nova Scotia Health Authority establishes standards across the province through their programs of care, which I've talked to you about before, we are meeting with each of them and saying, what can we do to help? We are exploring ways to work with our colleagues in primary health care to maybe even help them prioritize which patients should be seen the same day. I always use this analogy that if you call your family doctor, who do you speak to, and how do they decide whether you should be seen today or 2 weeks from now? And on what guidelines are they using to make that decision? So it's often their assistant, and and it might be the next available appointment. But what if we can partner, and we're trying to do that, partner with them and help use the guidelines to perhaps triage the people that are trying to see them and help and work through their appointments. So we're looking to trial that in some areas so that we might actually be able to help the primary health system to do that. And we did that some time ago with the Dal family practice, where the people were calling in during the day, and the nurses were quite uncomfortable about new complaints because they didn't know these were new complaints and there had been a bad outcome because somebody had called in with back pain, and they didn't have any evidence-based guidelines. So we helped Dal family practice so that people that called in would call us, and then if they needed to be seen that day, we would send them to Dal family practice. So that's one that I think is important. The idea of chronic disease management is something that's very appealing to me, and the future of that is quite interesting. And there are a number of people in the Nova Scotia Health Authority, researchers looking at chronic disease management. I think the model probably needs to change at some point. I think most people that come in who have diabetes also have hypertension, also have they might have COPD, and they have something else, and yet our current model, my colleagues, many of my good colleagues would acknowledge this, is that we divide those parts of the person up, and you go see your lung doctor, and then you go see your heart doctor, and then you go see your diabetes doctor. Your family doctor is sort of quarterbacking all that, but to actually have a chronic disease, and then what could we do to support that? We did do a trial some time ago. It didn't quite take off, but part of trying to do something different is you have to fail. you know, you have to fail, but we looked at using it for diabetes and supporting people as an outpatient in diabetes. I think there is a role for us as 811, not just to be on the receiving end, but to be on the calling end and helping people and doing that. So there's a couple other programs that you should be very proud of from this province. One is called the Inspired program. Some of you may have heard about it. Inspired was a program that was done by Graham Rocker. It's gone across the country, and it has to do with the treatment of COPD, and we've partnered with them. There's a lot of great things that are happening in Nova Scotia. We just sometimes need to talk about them a bit more. But back to your question, what is it? I think it is this ability to connect and serve as a platform with all these other things. So like I said, with Drew Bethune, will be a connection there. Mental health, which is a struggle, and you know, we're not the answer to mental health in the province, but we can connect to the answer, and we can act to that. When people end up with us, we can call and connect people to mobile mental crisis and the like. Yeah, so there's a lot of different things like that that I think we can do. Just a moment on our quality. I just want to brag a little bit about Natalia. I mean, it's a little bit different, right? So as many of you know, I have some other leadership positions, and I often have to, as such, deal with potential concerns or complaints. So I just wanted to talk about that if I could for a moment. So, and I would encourage you that people do call us because they're unhappy with the service. And like any mature service, we need to welcome those concerns and recognize whether there may be something there that needs to be done. So the process when you call 811 and there's a concern is Natalie investigates it, we talk to the person, it may be a provider, I may call them, we find out what's going on, we review the case, and when we review the case, it is unlike anything else I've ever done because 100% of the interaction is recorded. Can you imagine? It's sort of like this, I guess. But 100% of our interaction is recorded. So it's not like, you know, what did the nurse say to the doctor? What did the doctor say to the patient? You know, what was the body language? It's 100% recorded.
1 minute.
Yep. So, there, I can talk forever. So, so it's unlike that. And then we typically will get back to the person and figure out what's going on. I'll cede my rest of my 1 minute to you.
Ms. Miller?
I just want to be, again, thank you for the service. And I don't know which government started that, whether it was the end of the Conservative government or the NDP, but I certainly want to give credit where it's due. It's a great program, and thank you so much for all your work and dedication. Thank you.
We will then turn it over to the PC Caucus. Ms. Adams.
Thank you very much.
14 minutes.
Thank you. I'm just going to ask the one question we didn't get finished. So the Nova Scotia Health Authority by the numbers report for 2018-19, there's one every year, and this one specifically states under care delivery, it says beds, staffed and in operation. So 2017-18, there was 3,554 beds staffed and in operation, and that the next year was 3,150. So that's 400 less beds. And we hear all about the escalating emergency room closures across the province over the last few years, which is causing havoc. But I'm wondering if you have any comment on why we have 400 less beds in operation from one year to the next.
Dr. Howlett.
So today I've come here in my role as the medical director for 811, and as such, I would respectfully like to answer questions related to 811. So thank you.
Okay. Mr. LeBlanc?
Thank you, Madam Chair. Again, thank you very much for joining us here this morning to discuss this important system that plays an integral part of the healthcare system here in Nova Scotia. So just to be clear, your role when it comes to the need a doctor registry is strictly collecting names and data?
Dr. Howlett.
Yeah, and I think we've been asked to perform another role, but is to call the people on the list and verify whether they have a doctor or not. But again, that data is not our data; it is data that we're sharing back to the Nova Scotia Health Authority. So. Yes, so I think I'm getting that correct. So they call in, need a family doctor, we take the information, we pass that on, and then more recently, I think there was 20,000 people that we contacted just to find out if they're still on the list. I literally do not review the data, don't have the data, but it was, I think, a building upon scenario that 811 was a number that everybody knew they could call, and it was easy rather than create a new number. Yeah.
Mr. LeBlanc.
Thank you, Madam Chair. Thank you for that answer. It's just, I guess when we're going to be discussing questions to how we're dealing with the registry and taking people off the registry, it'd be nice to have some guests from the Department of Health or NSHA. When it comes to, what's the average wait time when people call 811? Is there a delay when it comes to answering the phone?
Oh, Ms. Boutlier?
Thank you for the question. We strive to answer our calls within 30 minutes, 90% of the time. And for the most part, we're very successful in doing that. We do have non-clinical staff that, if the nurses are all on calls, that the non-clinical staff will answer the call within 20 seconds, 80% of the time. So what we will do is we have a prioritization list. So if the non-clinical staff deem that the call an emergency, they have the ability to transfer directly to 911. Or if they deem the call high or more urgent than a medium call, if you will, then they could transfer that patient directly to a nurse. So we ensure that there is no delay in care. If the call is of an urgent matter, we take care of it. Otherwise, we will call our patients back within 30 minutes.
Mr. LeBlanc.
Thank you for that answer. Earlier you noted that 70% of the calls received are repeat calls. That's a very large percentage. You spoke about the 811 chart. In your system, is there a patient database or patient charting database that there's a follow-up? If I call today with one complaint and I call next week, is there a way that your nurses can actually follow up on the same patient?
Ms. Gallant.
Thank you for the question. So each record of the patient is kept, but each transaction or each call into our service is kept separate because they are calling in for a different symptom. Perhaps symptoms have changed or worsened in that, so we do keep them as standalone for each call. There are certain situations, depending on what recommendation that we are giving, that we will follow up with the patient in an hour to see if that interim care advice that we have given them has worked. If it has, that's great. Then we'll continue to provide them more advice at that point in time. If not, then we may recommend for them to go and be seen, just depending on the severity of their symptoms. So there are times that we do telephone callbacks within an hour, depending on the situation.
Mr. LeBlanc.
Thank you very much for that answer. Earlier you alluded to time frames that are acceptable for different patient outcomes. If I have one ailment, targeted time to see my doctor the next day or 2 days or within the week. Does 811 collect information to see actually if that timeline or those timelines are actually achieved?
Dr. Howlett?
No, though that's not completely true. We do a call out to we do on a percentage of our patients a call out to find out what actually happened. Ideally, this is the outcome-based research of trying to sort out what's going on, to say we made this recommendation, what did you actually do and how did you actually get in. That issue is usually dealt with at the front end, i.e. if we say to the patient, you should see your family doctor in 2 days, and they say it takes 6 weeks to get in and see my family doctor, the nurses typically will problem solve at that point. They won't say, well, good luck. They'll say, okay, where else could you go see somebody? And one of the concerns sometimes is people end up in the emerge because there's no other option other than to go to the emerge, but it was not our intention to send them to the emergency department per se. And it's interesting, it sort of works out, and I'll explain why it sort of works out. In the major areas where the emergency departments are I work in a major emergency department at Dartmouth General, and very high acuity emergency department. Cape Breton Regional Hospital, very high emergency department. QE2, very high emergency department. As you get out of the city, the emergency departments tend to be less high acuity, just by the nature. It's just a population thing, how many people are there. So, but in the major cities, there's a lot of walk-in clinics. Again, it's numbers, so you can move them to a walk-in clinic. But if you go to smaller places, it's not necessarily the Cape Breton may be different, but it sort of works out. But yeah, and just so that everybody's aware, when you call 811, the first thing that if there's a nurse available, they can pick up the phone. But it is our telehealth associates who take your call, and then we've created a clinical, categories of high, medium, and low, urgent things, and then the nurses call back, and then we measure both the call, and the call to pick up the phone is less than a couple of minutes, 20 seconds. The callbacks are 90% within 30 minutes, and occasionally we struggle with that. I mean, like anything, if there's a manpower crisis, I mean, we do that very well, but there are occasional times when we don't need it. Yeah.
Mr. LeBlanc.
So earlier you stated statistics based on the outcomes in our province with the 811. So 4% go to 911, 1.9 go to poison control, et cetera. Are there regional breakdowns of these outcomes? Is that something that's available?
Dr. Howard.
I'm a Mr. as well. A father as well. We have not looked at it like that. It's a great question. We could probably look at it like that. There's no reason we can't. We do, interesting enough, because as I mentioned earlier, we have PEI, so we actually break out PEI from us. We have presented previously to the zones, the 4 zones, so there's no reason we can't do that. And we could create that data and just say, is there something specific around one area where we send more people to it? And that would be something really interesting to look at. But I don't think we had a thesis or a hypothesis that it would be different in an area, but it'd be worth looking at for sure.
Mr. LeBlanc.
Certainly, because when we're examining issues of hospital closures and overburdened emergency rooms, it'd be certainly nice to have a regional approach to examining these different percentages. We spoke earlier about, we're talking about outcome research. I like data, I like information and that, and those reports. So 811 operated by EMCI, the pre-hospital ambulance service is operated by EMCI. There's an opportunity to share information there and conduct internal research. So I guess just because a patient is forwarded, those 4% of your calls are sent to 911 doesn't necessarily mean that there's actually a patient transport out of that. So internally, are you guys performing outcome research?
Dr. Howlett?
Yes, almost like you set that question up. Thank you. I don't think you knew that. Yeah, we actually have a meeting to set up to look just as a continuing quality stuff with myself, Dr. Travers, Natalie, and the equivalent of Natalie at EMCI to internally do a CQI to review all the patients that get sent from 811 to 911 and how we're doing it. Yeah, we're in the process of looking at that. Yes.
Mr. LeBlanc.
Thank you. And just to be clear, I think my colleague asked the question earlier. So if a patient does call your service, is there a family physician, if they're lucky to have a family physician, are they notified of the call by any manner?
Dr. Howlett.
They're not at this point. I mean, it certainly could be something we do. We'd have to figure out how to do that, but we are meeting, or I'm planning to meet this fall, hopefully in the next month, with the GP Council at Doctors Nova Scotia, and I don't think that I've ever had anybody come and say, "I wish you told us that they called 811," but I'll bring it up during that conversation. It's a great thought, actually.
Mr. LeBlanc.
Thank you. So 811 operated for PI in Nova Scotia at the same time. Is it the same nurses that are operating for both provinces at the same time?
Ms. Boutlier.
Yes, it's the same nurses.
Mr. LeBlanc.
And are those nurses from PEI or are they from Nova Scotia?
Ms. Boutlier.
The nurses actually work all through Nova Scotia and PEI.
Mr. LeBlanc.
Do we know percentages of Nova Scotians versus PEI?
Ms. Boutlier.
Don't have those exact numbers. We do promote the nurses to work from PEI. It's a matter of recruiting them, and we do our best to recruit nurses all through Nova Scotia and PEI.
Mr. LeBlanc. You have 2 minutes.
2 minutes, thank you. Speaking a little bit about the list, if my grandmother, who's 70+ years old, gets a phone call saying, we have a family doctor for you, and that doctor is greater than an hour away and she's not comfortable driving more than an hour, and she declines that opportunity for that family physician at that time, what happens to her priority on the registry, if you're able to answer that?
Dr. Howard?
Yeah, again, I'm not ready to, I'm not able to answer because I don't have that data, and we don't manage that list. Just back to your question, I just asked, there's one nurse on PEI, and the rest are from Nova Scotia.
Mr.
And there's one in New Brunswick, just to...
Mr. LeBlanc.
And I assume that you guys go through clinical auditing, quality control for your calls?
Ms. Gallant?
Thank you. Yes, we do have a rigorous program in terms of call auditing and monitoring, and that's based on their performance and also on their experience as a telehealth nurse. So we do work closely and we monitor that on a monthly basis.
Mr. LeBlanc.
How much time do I have, Madam Chair?
Less than a minute.
Okay, and just want to make sure for the record, that are you guys private with the MCI or with Department of Health or Dr. Howlett?
Dr. Howlett.
Private.
Mr. LeBlanc?
I guess, are there plans to examine improve patient outcome, or not necessarily patient outcome, sorry, the tracking of the patient outcome?
Dr. Howlett.
Yeah, absolutely. So the two
Order. Time has lapsed. We'll turn it over to the NDP for 14 minutes. Ms. LeBlanc.
Thank you very much. Before I ask my questions, I also would just want to give 3 cheers to 811. I have, as a mother of 2, I've done many calls in the middle of the night, and I have to. That's actually part of my first question, because in my experience, I think if I think back to the times I've called 811, it's mostly literally been in the middle of the night or 11 o'clock, sometime when a walk-in clinic's not an option, or it would be a real pain to get up and get out of the house kind of thing. So we call 811 first. And so I'm wondering if you have any statistics on like how the volume of calls at different times of day.
Ms. Boutlier.
Thank you. So yeah, our call volumes do vary. Generally in the morning, our call volumes are quite low, and as the afternoon goes into the evening, around supper time, when everybody starts getting home from work and school, our call volumes do increase, and they do decrease overnight. They decrease from midnight on. It's a lower call volume.
Ms. LeBlanc.
And so I guess I just wanted to connect that with something Dr. Howlett said earlier, which was, this is also going to go into another question, but Dr. Howlett earlier mentioned something around saying that the 811 system hasn't lessened the people who go to the ER, but has changed the people who go. Is that an accurate, number one, is that an accurate retelling of what you said?
Dr. Howlett?
Yeah, I think that would be a fair representation of what I said, and it'd be accurate. Yep. And so just if I can expand on that, there are some people that were able to manage at home, but there were some people that were staying at home that quite rightly should go to the emerge. And it is quite humbling. I get a lot of flack for being the emergency doctor associated with 811, as you can imagine, because my colleagues, busy emerge. But it is also quite humbling, to bump into somebody that literally says, hey, you saved, the program saved my kid's life, right? Like I called and this happened to me at, when I was at Capital Health. One of the PR people just said, look, I was calling in, I was in charge of the kid, mom was away, and I said, how much Tylenol should my 5-month-old have? And they said, your 5-month-old shouldn't have Tylenol, your 5-month-old shouldn't have a fever, you need to get to the IWK. And he said, so we went to the IWK, they had a serious bacterial infection, they did well, and they said, thank goodness you showed up. So, those are some of the things that are quite rewarding about this program.
Ms. LeBlanc.
Right, and earlier listen, I think the program's awesome. Earlier you also mentioned, at the very beginning, you said, assuming you do have a phone, like the service is available to all Nova Scotians, assuming you do have a phone. That's kind of a big point, a big important point here, because in terms of people who don't have phones, obviously they are people who can't afford a phone. And so I'm wondering if you can comment on that. Like, do you see, in terms of being an ER doctor, would you say it's fair that the people who then present at emergency are people who don't have access to the 811 system first, like that they haven't had that sort of first line of triage? Or would you, and I guess secondly, would you suggest, or would you agree with me when I say that every Nova Scotian should have a phone?
Dr. Howlett.
It's a lot of questions in there. And thank you for that, Susan. So you're, fair. I look after Dartmouth General. A lot of my favorite people come from Susan's riding. So, and they are some of our more hard-scrabble people in our society, less blessed than you and I. But most of them have phones, interesting enough. So I don't see very many people who don't have phones. I can count on one hand in the last month the number of people who don't have phones. So somehow that seems to. So in short answer, yes, I think the phone should be. I think 811 is helpful. And it's a matter of continuing to educate people to call it when they do, I was trying to make the differentiation between the internet and the phone. That that sometimes we think, why is this all internet based? I think very few of these people may not have access to reliable internet. I think that is really where I see the difference in many of the people I see. But most of them seem to have access to a phone.
Ms. LeBlanc.
Well, I'm glad that's your experience. I have to say that I have many people come into my office who come in to use my phone. But I wanted to ask a bit about the nurses working from home too, which is something that as someone who calls 811, I had when you see someone who's on the radio personality in person for the first time, you're like, this is not at all who I thought you were. That's how I'm feeling about 811 right now, because I had this image of all these nurses working together in this cozy office and everyone on the phone together. So the nurses work from home. So can you talk about that? Are they, because they're not connected with a site, are they unionized? Are they paid in the same way as NSHA nurses or people who are working, in sort of more conventional nursing situations? And is it this EMCI, which I'm assuming is a company, I'm kind of lost track there, is like, who's paying the nurses?
Who wants to take that? Okay, Ms. Boutlier.
Thank you. So yes, all the nurses work from home. They're non-union nurses. They have various backgrounds and experiences that we're looking for. And so you had a lot of questions there. What's another question that I could answer there?
Ms. LeBlanc.
Who pays them?
Well,
Ms. Boutlier.
Thank you. EMCI pays them. We work for EMCI. I mean, we regulate it through the Department of Health and Wellness, but we work for EMCI.
Ms. LeBlanc.
So just to be clear, EMCI is a company that runs this system that the department contracts to run 811 for the citizens of Nova Scotia. And you folks are paid by EMCI and the nurses are paid by EMCI.
Ms. Boutlier.
Correct.
Dr. Howlett.
And the same thing happens with EHS, right? The EHS system is a very similar agreement. But I just wanted to talk a little bit about the nurses if I could, because it's not intuitive, you know, what these nurses are. And what they do is, and I spend a lot of time with them. We have this it's kind of goofy Ask Dr. Todd session regularly, but we spend a lot of time doing some education. But what the nurses do is very difficult. It is as much of a nursing, you know, and these both two are nurses, and I'm an emergency physician. I work with a number of people, but what they do is very difficult. So I want to brag about what they do. It is very hard to, over the phone, assess a sick person and decide what's wrong with them. It is as much as a specialty skill as being an ICU nurse, being an emerge nurse, and it is not for all nurses. Some of them think, hey, I'm going to go home and I don't have to go anywhere else. And then they try it and we're like, whoa, this is way more difficult than it is. And unlike a lot of the nurses that work when I work, is many times they're the final word on the patient. They've seen the patient and they're leaving the patient at home. And that is very different than from when many of them have come, because it's often there's been a physician. That doesn't mean that nurses don't work with some independence, but typically they work in a team, where in this case they may actually be using a guideline and recommending self-care. So we spend a lot of time doing that and lots of time to figure that out. So we have some excellent, well-trained nurses, and this skill is very difficult to do. There are some advantages. We have nurses that, and they have to be in an office. They cannot be in the kitchen. They're set up specifically. They do home visits. It all has to be done very professionally. They're expected to dress properly. They can't show up, roll out of bed, put your pajamas on, start taking calls. It doesn't work like that. So it is important that, and it's difficult. It does allow a group of nurses that may not be working somewhere else for whatever reason, or if they have internet connection, they may be able to stay with their family somewhere in a rural area and do this. As long as the real challenge is we have to have high-speed internet connection to allow them to do this. Yeah.
Ms. LeBlanc.
Yeah, so given those special skills and that sort of particular way of working, can you talk about the comparative salary of a 811 nurse to, say, a nurse working at a hospital?
Ms. Boutlier?
Thank you. We do strive to do comparative salaries with our nurses based on the hospital wages.
Ms. LeBlanc?
So the nurses who work at 811 are paid the same as nurses at the hospital?
Ms. Boutlier?
Again, we strive to match what the wages are in the hospital.
Ms. LeBlanc?
So I'm sorry, you're saying you strive to match the wages at the hospital, which suggests to me that they don't make the same as I'm just asking the question. There's no judgment. I just want to know. And also, I'd be curious to know if they have health benefits.
Ms. Boutlier?
We absolutely do have health benefits. So we strive, again, we strive to match, and it's performance-based. So we do yearly performance reviews with our nurses. And so on a yearly basis, we do increases based on performance. So it's performance-based payments or salaries.
Ms. LeBlanc?
Can you talk about what the base salary is, like the starting salary?
Ms. Boutlier?
I think I'll pass on that question at this time.
Ms. LeBlanc?
Well, I think it's important for Nova Scotians to understand what people who are serving them are making.
Ms. Boutlier?
Sorry. So I just wanted to be sure I was allowed to reveal that the starting wage is $36.78 an hour we start our nurses with.
Ms. LeBlanc?
And that goes up annually or whatever based on performance.
Ms. Boutlier?
That is correct.
Dr. Howlett?
Sorry, I think we're all a little bit uncomfortable because we've never been here before, and we want to make sure we get this right. So I don't know exactly because I haven't been involved in the wage gaps, and I understand why you're asking the question. It makes a lot of sense to me. One of the things that we know about the nursing here is we seem to have found an opportunity to find nurses that want to work in this environment, right? And the other thing is many of them will also tell that there's a lot less expenses if you don't have to travel to work. And there's a bunch of other things that specifically around parking or traveling or cars and everything else. So it does provide a certain economic advantage if you can actually find a job where you work from home. So.
Ms. LeBlanc.
Yeah, I totally get it. I think, obviously there's many different working situations for many people and things work well for people. I know that I have a sister-in-law who worked at home for many reasons and it was really perfect for her and she lived outside the city. She didn't have to deal with any of that stuff. So, but I'm wondering if you could, we don't have to discuss any further now, but if you could table or send us with the other data that you're sending us, the information around how those performances work. So, what would the annual review entail and what happens if a nurse is not meeting their performance targets? Does their salary go down? Does it stay the same? Those kinds of, that kind of information, that would be great. I'm just going to move on to talk a little bit about the integration of the 811 system with, like in the future with the electronic one person, one record. Are you sitting like that because my time's up?
Not yet. Soon.
Can you talk about, is there a future of integrating 811 with one patient, one record, and so that, a Nova Scotian has one chart, which 811 would also be included in?
Dr. Howlett?
It's fully my expectation that we will be included in that. It's from my understanding. I don't think we've not had those conversations now, but it is my understanding, Susan, that we would be included in the OPOR, yes.
Okay. Ms. LeBlanc?
How much time do I have?
Just 20, about 20.
Wondering if there's any way to currently look, until we get one patient, one record, if there's a way to, to maybe implement this idea of having records or the 811 call be transferred to.
Time has lapsed for the NDP. We'll move it over to the Liberal Caucus, 14 minutes. Mr. Irving.
Thank you, Madam Chair, and thank you all for being here today. I just wanted to go back to trends of usage. You mentioned there were 114,000, I guess, individual calls and 80,000, I think I understood 80,000 individual clients in the course of a year, but you also inferred that numbers had dropped a bit. So I'm just wondering, over the 10 years, removing the blip of it wasn't SARS, but anyway, the H1N1, is there a general downward trend over a number of years with respect to the use?
Dr. Howlett?
So I don't have it in front of me, so I'm happy to get it to you and you can look at it. It is my memory that it has come down a bit. One of the things that we do know is that every time we embark on an advertising, we do have an upsurge, and I think there is an opportunity there that we haven't. It has gotten much better. We initially, the coordination between advertising and us being aware advertising wasn't always perfect, and so we suddenly advertise and our volume jumps 30% overnight, and then it comes off. But we're much better at knowing that, because sometimes it has staffing implications if we're not ready for that. So yeah, so I think I'll get that data for you. I do think advertising is part of it, so I'll leave it at that.
Mr. Irving.
Thank you. And to that point of advertising, in terms of advertising your own services, when we have people calling up to be put on the Need a Family Practitioner list, I assume that you do. I mean, it would be the perfect opportunity to say you can always call back. You don't have a family doctor. We're here to help fill that gap, or during this waiting period. Does that actually happen?
Ms. Boutlier?
Thank you. Yes, that does happen. So if they do call the Need a Family Practice line and they are exhibiting symptoms or are requesting health information, the telehealth associate will refer them back to 811.
Excuse me, Ms. Boutlier.
Sorry, to call 811 back to speak to a registered nurse.
Mr. Irving. Oh, sorry, Dr. Howlett?
So one of the other things we're working with some of our primary care colleagues to make sure that it's on their answering service. So if you call the family doctor's office as well, it's how you've reached Dr. Jones's office. It's after hours, it's emergency. Please go to your local emergency. If you're unsure what to do, please call 811. So, there's a education that's happening in there as well. Rick Gibson, who you may have met, who's the senior physician for primary health care, has been very good about putting that out. That the whole adage is if it's an emergency, go to emergency. If you need to see your family doctor, go to the family doctor. If you're not sure, call 811.
Mr. Irving.
Thank you. Now, the high number of repeat calls, and I'm sure many of them, like Ms. LeBlanc with 3 kids, are, use the service over and over, and it's providing great value. I'm just curious whether there's any kind of very much low need use, seniors that are lonely. I mean, that's kind of a mental health thing as much as anything, but as any politician who knocks on doors, every once in a while you meet a senior that wants you to sit down and have a long conversation. And I'm wondering if that is something that happens in this service, and whether nurses are trained to try and weed through the loneliness calls, I guess.
Dr. Howlett?
So first of all, I just want to say, I think Susan only has 2 kids, but just wanted to make sure that was understood. I just can't, yeah. So, thank you. Not so much. I think, our experience with the elderly is they don't call this line for, just for loneliness. I'm not sure why. It may just be because they respect it and they don't want to do it. We do have a group that in Emerge we would call familiar faces that now use the line. We call them multi-caller or multi-visit patients that are sometimes difficult to manage, and they may call for all kinds of interesting reasons, some of which we have to actually create care plans around what they would do. They're calling to interact with nurses or in an unusual way. So that's a reality, but that's a reality in anything. We see that in the emergency department, and it's not surprising we'd see it on this. But as for elderly, no, I don't think we've seen that as an issue. We do some outreach, of course, from provider referral to various things that we can help people. I can imagine, though, that once you sit down for tea, you're there for a while.
Mr. Irving.
That's right, and I do agree with you. I mean, we're in public service and we're serving the public, so I appreciate your comments there. I understand you also have a website and online services there. Do you have any sense of whether that is providing, through hit rates or whatever, providing service that are foregoing calls and providing advice without talking to a nurse, but helping folks navigate to the most appropriate health professional to deal with needs? Could you tell the committee a bit more about the online services or your website?
Dr. Howlett?
Thank you. I'm not aware. I was just asking if we had any data on hit rates. I think, so the answer is I don't know. And I'll be honest with you, I don't know whether that, like we're exploring whether we can put symptom triage online. So we are exploring that. It's fraught with some other areas have done that. And we're perhaps looking at doing it. We had quite a conversation yesterday at Clinical Advisory Committee about the pros and cons of doing that, about just letting somebody go through a list and doing their symptoms and not having a nurse assist in that process. I think it's really important. A lot of people ask, why can't you, if it's just a pick list, why do you need nurses? Well, that's kind of a silly question. There is an art to it. You need to have somebody, you need to clarify a question, you need to have a healthcare provider to basically say, it sounds like this, or the person might minimize their symptoms. For those of us that work the front line, we know that some people minimize their symptoms, some people are on the other end of that spectrum, and we're always trying to sort out where and help the person understand what's the most accurate symptom and what's the most accurate disposition for them. Not sure, we're still struggling a little bit and we're trying to get some data from some other areas about how successful they are using an online one and what are the results of that. So that was actually on our action item from yesterday to figure that out. So we are looking at that, yeah.
Mr. Irving.
Thank you. And I guess I just have one more question before I turn it over to my colleague to the right here. And it goes back to data. I was just curious whether you had any kind of regional data that indicated any trends that, regionally that are helpful for healthcare planning.
Dr. Hallett.
Yeah, I know some time ago we presented a regional data around zone. So maybe I can put it back to the committee because, I mean, we're planning to meet with the Nova Scotia Health Authority again and we'll probably break it out by zone. And I guess the question for the committee, if I may, is how granular would you like the data? And would you like it, based on the people who vote for you, or what are we actually looking for?
We don't normally do answering questions in the reverse, but it's interesting. You can give us thought to ponder, for sure, and people may want to submit from their caucus if they have suggestions to you, but normally it's not our process.
Sorry about that.
Mr. Irving?
Thank you. I mean, I think the purpose of my question and other members on the committee is it really does seem like there is valuable data within this service, and I just encourage us to find ways to investigate that and garner the benefits of that data, because it is, I think it does have value to the system and our hospital planning or health services planning. So with that, I'll turn it over to my colleague to the right. Thank you.
Mr. Jessam.
Thank you, Madam Chair. Through you to our witnesses, as the intake mechanism for Nova Scotians attempting to find primary health care, find a family doctor, does your shop have the capacity to triage patients as they're making call based on who has a higher need than perhaps the next patient?
Dr. Hallett?
Thank you. So if I understand your question correctly, are you specifically talking about the symptom of the patient, or are you talking about whether the patient is a family doctor?
Mr. Jessam.
Through you, Madam Chair, I'm referring to the group of Nova Scotians that do not have a family doctor. Does your shop have the capacity to triage, 1 to 10, who is in highest need, who has the highest urgency to be matched to a family doctor?
Dr. Hallett.
Again, thank you. So again, just on the need of family practice registry, we don't, other than collect the data and pass out to the Nova Scotia Health Authority, we're not involved in taking people off the list, calling them back, giving them a family doctor. That resides completely with the Nova Scotia Health Authority.
Mr. Jessam.
So my question is, would your shop have the capacity?
They don't do that.
I appreciate, Madam Chair, that they do not do that. I'm asking, do they have the capacity to do that?
Dr. Hallett.
I believe I understand your question now. We have never been asked to do that at this point. I would have to talk to some people and see whether that would be, whether we could do that. It's an interesting proposal. It's never been asked. So, there clearly have to be criteria, and so there's a bunch more. I haven't put enough thought to it to actually answer that question in a meaningful fashion, if that's helpful.
Mr. Jessam.
Do you think that, I guess I'm trying to understand, would it require the intake personnel to have, a certain background, or would it be something that, a questionnaire or something along those lines that any intake person could administer.
Dr. Howlett?
Yeah, I mean, there's been conversations amongst physicians outside of this about, they have somebody who has, 3 chronic diseases and perhaps they have a priority for a family doctor. I'm sure there could be criteria established, whether that would need a clinical person, non-clinical person to administer it to the patient. I'd have to give it some more thought and involve some people maybe smarter than me right now to figure that out. But, I think that would be an approach that would make sense somehow, yeah.
Mr. Jessom?
For those people who call in without a family doctor, are you informing them automatically about 811 as a service?
Ms. Gallant?
Thanks for the question. Yes, that is part of our process, that we will advise them that if they have symptoms, that they can call 811 24 hours a day.
Mr. Jessom?
And oppositely, would those who call in without a family doctor automatically be added to the 811 list?
Ms. Gallant?
It's not an automatic part of the process, but if they ask, then we can definitely transfer them over to the Need a Family Practice program. If it's during regular business hours, if it's after hours, then we would advise them of the hours and to phone back and to be added to the list for sure.
Mr. Jessom?
Thank you for your time.
Are there any more questions from the caucus? Okay. We will now ask our, time has elapsed. Dr. Howlett, would you give some closing remarks?
Yes, thank you. I'd hoped that we would have a meaningful conversation, and I'd like to think that we have. I'm also been very impressed by a number of the speakers and some really interesting, tough questions and some ideas. So, I came here with an idea that hopefully we would educate you, but I've heard some great stuff from you, and so thank you for that. And we'll take some of those ideas back and challenge ourselves to continue to do better to serve the populace. I do believe strongly that 811 has a role to play in our healthcare system and helping coordinate it. I don't think it's wrong to suggest we have some work to do still. And I think 811 could be part of that. The one plea that I asked about was if there's some way that we can, mandate a federal, I think you've heard that from me, but a federal mandatory working group by all third party. I think that would be very helpful. I think it would challenge us and allow us a benchmarking and prove, that we can do things in Canada. It's the Canadian way, but sometimes when you put the third party in, there's a lot of good things by the way of having a third party run this organization. There's an accountability and a rigor that I've seen that I don't always see in my other job. So there's some, there is some really good things to that, but like anything, there's a negative side to that. So I just wanted to again express my appreciation and thank you for coming here and anything.
And thank you, Dr. Howlett, Ms. Gallant, and Ms. Boutlier. You may leave. I'm sure there are people out in the media gallery there waiting to interview you. We have a short business meeting. We started the meeting a little late today, so we can't stay here forever because Ledge TV needs to get in and use the room. But can we have like a 5-minute extension in case we need it? Do I have consensus from the entire committee? Thank you. We will move on. We have a bit of business. The NDP had asked for representatives from the College of Dental Hygienists and for the Deputy Minister of Health and Wellness. The committee approved, along with a Liberal amendment that added Angela Purcell, the Dental Association Executive Director or Designate, but it should be clarified that Ms. Purcell does not work for the Canadian Dental Association. She is the Executive Director of the Pharmaceutical Services and Extended Health Benefits with the Department of Health and Wellness. Given that new information, does the committee still wish to invite Ms. Purcell to attend the meeting? Do we have consensus on that?
This was not the person that we asked, right? This was the...
You asked, but her position was different than from what I understand. She is the Executive Director of Pharmaceutical Services and Extended Health Benefits with the Department of Health and Wellness. Yes. Ms. LeBlanc?
My understanding is that this was the person that the Liberal caucus wanted to add to the roster of witnesses.
So you're fine with that? Yes? So we have consensus from the committee? Okay, great. The 2019 annual report, we'd like to have approval. You were all sent it by email. Do we have, can we have a motion to approve and have it sent to the legislature? Mr. Jessam?
So moved.
Okay, all those in favor? Opposed? Motion is carried. So, Ms. Kalanoff, you will get that ready, and I will sign it, I guess, today after the meeting. We also have a correspondence from Dr. David Anderson, Dean of Faculty of Medicine. You received that. It was a request from the August 14th meeting. You received it by email from the clerk. Are there any comments or questions? Okay. Our next meeting date will be Tuesday, November 12th, 2019. We are hoping it will be 1 o'clock to 3. It may be, if the House is still sitting, it will be in the morning. Ms. Adams.
Thank you. At a previous Health Committee meeting, I had asked for hierarchy charts for the Department of Health and Wellness and the Nova Scotia Health Authority, and to date I haven't received them.
Is that the organizational chart? I do remember that, yes. Ms. Kalanoff.
I have written to the department and asked for that. It normally takes a week or so to send these letters out to witnesses because we have to wait for the Hansard transcript to be available. So I make a list of all the requests that were made in the meeting, send it to the departments, they've received it, so we're just waiting now.
Ms. Adams.
Thank you. And just to clarify that was both for the Department of Health and Wellness and for the Nova Scotia Health Authority.
Ms. Kalanoff.
Yes, I wrote to both organizations.
Okay. Thank you. Any other questions? I will adjourn this meeting. Thank you.